importance of early diagnosis and optimal treatment. For this session, our expert speaker is Dr. Ruchir, pediatrician in Thane, and also an amazing singer. Kindly remember and wait for the fantastic cultural night that we have today. And Dr. Alok Sardesai. Please be seated, Dr. Ruchir Parekh.
Hello. Dr. Ruchir Parekh is a...
I would request Dr. Kelkar sir to introduce Dr. Ruchir Parekh.
Dr. Ruchir Parekh is a pediatric and adolescent endocrinologist, and she has special interest in prevention of congenital hypothyroidism, and especially bridging the gap between pediatric and adolescent and adult endocrinology, because many of the diseases are overlapping and they go on for a long period of time. So I hand over the session to
Thank you, Dr. Kelkar, for the kind introduction. And at the outset, I would like to thank the organizing committee and the president of TAPICON for this kind opportunity. So, as sir, you rightly said, and as the image also depicts, pediatricians are the important bridge to identify and to send the patients to these specialties when needed. So, as pediatricians and neonatologists, you all know that birth weight is a major contributor to neonatal morbidity and mortality, and is also associated with long-term chronic diseases in adulthood. Out of SGAs and LGAs, low birth weight remains a major cause. In 2012, the data collected was predicting that SGA was observed in almost 20% of live births in low and middle income countries, whereas 22% of the neonatal deaths occurred in infants born SGA. So is the SGA a burden? We don't have enough data, as we don't have the correct gestational age or the birth length at the time of delivery. Worldwide, it is estimated that almost 2.3 to 10% of all infants are born SGA. When it comes to India, unfortunately, India has highest incidence of low birth weight and the SGA babies. And among these low birth weight babies, 70% are SGA. If you can look at that image, it is predicted, it was estimated in 2010 that India would almost have 46.9% of SGA babies. However, the small studies which have done locally in our country have given the correct answer, which is 25 to 28%. So yes, there is a huge burden of low birth weight and SGA in our country which needs to be addressed. So what is SGA? So SGA is defined as a neonate whose birth weight or birth crown heel length is at least 2 standard deviations below the mean for the gestational age, for the gender, and this is based on the data derived from a reference population. This definition definitely has a caveat. First of all, it is important to know the accurate gestational age, which is ideally based on the first trimester ultrasound examination. We should have the accurate measurements at birth of weight, length and head circumference, and a cutoff reference data which will give us the 10th centile, 3rd centile or the 2 standard deviation from the mean. However, it does not take into account the background growth modifying factors such as the maternal size, the maternal weight gain, the ethnicity and parity. So to identify the SGA at birth from the term and preterm, we know about 2 charts. One is most commonly used, which is the Fenton charts, which were released in 2003 and modified in 2013. But recently in 2014, we've got these Intergrowth 21 charts, which also includes India as one of the sample study. So this charts is from 33 week onwards, but they have also extended from 27 to 33. So terminology confusion, we all need to know what is SGA and how do we differentiate it from IUGR and low birth weight. So SGA is actually the size of infant at birth. So this is from the chart you can make out that there is a red line which depicts SGA, which is less than the 10th centile line. IUGR suggests diminished growth velocity in fetus in utero. So if you look at this line, or the red line, it is not below the 10th centile, but there is definitely a restriction of growth and there is a faltering of growth from 90th to 50th centile. So child born SGA not necessarily suffered from IUGR, and infants who are born after a period of IUGR are not necessarily SGA. So it is important to differentiate between the two. The most perinatal complications are associated with IUGR as compared to SGA. Okay, so this is the SGA and IUGR. Okay, where the child was having a growth restriction and was born small for gestational age. So this is child is way below 10th centile and there is a faltering of the centile lines. Low birth weight, it just includes babies which have a weight which is less than 2.5 kilos irrespective of the period of gestation. So this is low birth weight, okay, which is less than 2.5 kilo, and if this baby had an IUGR, it would be born at 2.5 kilos, but it would have a faltering of the growth centile lines intrauterine. So is there a need to identify SGA? Yes, there is definitely a need to identify SGA for the neonatologist because there is an important risk for perinatal morbidity. There is a lot of maturation that needs to take place, okay, and from the endocrine point of view, we are worried about two things which happens postnatally. One is hypoglycemia. Most likely this is going to be a transient hypoglycemia. This is due to the increased IGF-1 or insulin, or this could be the immaturity of the hypothalamic pituitary adrenal axis, which can be only a transient phenomenon. The second would be the osteopenia of prematurity. So if these preterm children are SGAs, then we are worried about the bones, the osteopenia and the calcium and vitamin D. So what are the associated health problems thereafter? Most commonly it's a neurodevelopmental disorder, so they do warrant a neurodevelopment assessment periodically. Persistent short stature, so those who do not catch up, so we look at this term, what does catch up mean? Okay, they end up with short stature and they also attain an adult height which is way below their target height. There could be variable onset of puberty, so there could be precocious pubarchy or precocious adrenarchy or the earlier onset of menarche with rapid progression and eventually attaining a short adult height because of the rapid progression of puberty. The metabolic disturbances and cardiovascular morbidities are common in adolescents and adults, and these are seen in children who have a rapid catch-up growth and they are at risk of developing the metabolic syndrome. So these children definitely after the neonatal course, after the NICU course do need regular monitoring. So they should be monitored every 3 monthly in the first year and thereafter every 6 monthly, and it should include weight, length, head circumference and the nutrition assessment. This helps to prevent consequences of short stature, metabolic syndrome and altered puberty. So what are the tools which are required for monitoring? There are only 3 main tools that are required. One is the growth parameter. Second is the ideal growth charts, plotting and assessment and interpretation, and at right time to assess the puberty. So these are the main parameters that we always do measure in every baby, that's weight. And for the growth, it is length less than 2 years and height above 2 years. What are the charts? We all know that now we have a country-specific charts right from 2015, and these are the growth charts that we should be using. So this is 0 to 18, blue for boys and pink for girls. The one marked with red is for weight, and the one marked with black is for length, for the height. And there are 7 percentile lines. Okay, this WHO MGRS has released the growth charts in 2006 for children less than 5 years, and this also included India as one of the sample country. So it includes the weight, the head circumference and the length. Besides that, because obviously in a busy practice we need to plot and identify the problem area. So these are the pediatric friendly growth charts which was released in 2020 by Dr. Khadilkar. If you see the first one, so this one, okay, here you don't need to calculate anything. You have weight, you have height. You have to, in this column, you just have to connect the lines between the mother and the father, you'll get the mid-parental height. And for the body mass index, you don't have to calculate anything. You just have to plot the length and the weight, and you will get the answer to underweight, overweight, or obesity, which is now improved to this chart, which includes another 2 lines, especially that minus 2.5 line which is required for the SGA. So this is a quick screening tool which will help you to identify and refer. Okay, the next would be the height velocity curve. So any child who has a height velocity curve below the 25th centile, as you can see here, okay, so this is a normal growth velocity. Anything below that would be a growth faltering, and these children need to be referred. So besides height, we also need to look at the weight. So obviously we are looking here at overnourishment. So for children less than 5 years, any standard deviation above 3 is called obesity and above 2 is overweight. Whereas for children more than 5 years, we do have our Indian charts which are modified now, and we don't follow the 85th and the 95th centile for the overweight and obesity anymore. Because if you look at this from the IAP or the Indian Academy of Pediatric Charts release, the children who are overweight are actually matching the 63rd and the 64th centile. So we would have missed if we would have waited for the 85th centile. And the obesity is matching the 27th equivalent, which is actually in 89th. So it's important to plot on the correct growth charts. Okay, so this is the revised IAP growth charts, okay, for boys and girls. So this orange is indicating the overweight, which is 23rd equivalent to the adult, and the red is the obesity, which is 27th equivalent to the adults. Even for the adults now, the BMI has been dropped down from 25 and 30 to almost 23 to 25 and not even 27 now. So the other thing that is important for obesity is when they have a adiposity rebound. So this is a normal adiposity rebound, which is called a tick sign. It usually happens at 6 years of age. But if this happens before 5 years of age, then there is a risk of adult obesity. So BMI at 7 years will predict an adult obesity, and 50% of children who remain obese beyond 6 years of age will remain obese as adults. So it is important to identify these children at earlier age so that prevention can be offered to them instead of just waiting for a cure. Again, besides the growth charts, we have the IAP growth chart app, which also includes the length, the weight, and the BMI. It can also help you to measure the growth velocity. So using these tools, it will be important to identify what's happening with the height and weight in an SGA. The next is the SMR, or the pubertal assessment, and we all know that the age of onset of puberty is highly variable, and it correlates better with the bone age or skeletal maturation than with the chronological age. So important to know that in girls, the onset of puberty is with thelarchy at 8, which can happen between 8 to 13 years. This is followed by pubarchy, peak height velocity, and then menarche. So the peak height velocity happens before menarche. Whereas in boys, the onset is marked by testicular enlargement, which is more than 4 ml by Prader's orchidometer, and this can happen anywhere between 9 to 14 years. Here, the sequences, there will be a change, gonadarchy, there will be pubarchy, and there will be a peak height velocity followed by the facial hair and shaving. So if you can look at these charts, the peak height velocity happens before any changes that you see in the male, that is the voice change and the facial hair, and in girls it's before menarche. So if we have to make sure that they have achieved an appropriate peak height velocity, the referral should be before the menarche or the facial hair and shaving. As you can see, the peak height velocity can last anywhere between 1 to 3 years. It is 7 to 9 centimeter per year in girls and 9 to 11 centimeter in boys per year. Okay, so now coming to SGA, growth is the most important thing. This is because the children who are growing slow or who have a short height will continue to remain short adults, and they will have a height less than 1 standard deviation. By age 18 years, almost 8% of the adults born SGA remain short. There has also been a study which says that 20% of the adults who are short, they are actually SGA. So that's a very huge sum of adults remaining short, and the reason being SGA. So we all know that the what important things are required for normal intrauterine growth, and when there is a restriction, it is usually due to prolonged oxygen deficit and malnutrition, which leads to GH, insulin and IGF-1 resistance, and hence it slows down the growth rate. Whereas in postnatal growth, we know that the nutrition plays an important role. Even though the GH insensitivity is less, they usually catch up and it normalizes in a normal postnatal growth in term SGA. But whereas in postnatal growth in SGA fail to catch up, they usually have a higher plasma cortisol levels, which limits this IGF-BP3 proteolysis, and thus minimizing the availability of IGF, and hence they have early growth restriction. So the pubertal growth, so we've understood intrauterine, we've understood postnatal. Pubertal, what happens one is that these SGAs have a variable timing for the onset. They are usually 4 centimeters shorter at the onset of puberty. Also because of the accelerated bone maturation, they have a shorter time that they spend in the peak height velocity, and hence they land up having a much smaller height than the target height. So now, since we were discussing about catch-up growth, what is catch-up growth? It is actually an adaptive response for the SGA to achieve their full genetic growth potential. It is catch-up growth or catch-down growth is actually an increase or decrease in the standard deviation of more than 0.67 between 2 time points. This is approximately the width of each major percentile band on growth chart, which is moving from 10 to 25th or 25th to 50th, and therefore can be considered clinically significant. So in clinically, what does this refer to? That growth velocity is greater than the median for the chronological age and gender in the first few years of life. There is a crossing of the centiles, but it does not cross beyond the median, and it has to achieve a height which is more than below 2 standard deviation or third centile. The weight usually catches up in first 6 months and height by 2 years. 80% do catch up in 6 months. There is a small possibility of catch up even between 2 to 4 years for especially children born premature. The ones who are extremely premature and extremely low birth weight can take even more than 4 years to achieve a height in the normal range. But when we look at any syndromic children like Russell Silver, their growth will be incomplete. So yes, eventually 85 to 90% will catch up, and there are no predicting factors like growth hormone, IGF-1 or ponderal index which will tell us that these children will not catch up. However, the children who do catch up, they have an increase in the IGF-1 levels, which is probably contributing to their catch up of growth. So what are the indication for referrals? Now we do have that pediatrician friendly growth charts. So any SG under 2 years of age with current length below 2.5 standard deviation, or between 2 to 4 years and no evidence of catch up and height less than 2.5 standard deviation, or above 4 years old and the height being less than 2 standard deviation. So the children who actually remain below 2 standard deviation or below third centile or below the MPH range with poor growth velocity definitely warrants a referral. And why a referral? Because growth hormone therapy has been approved nearly 20 years back for such children who fail to catch up. And the goals are first to increase the height velocity and normalize in early childhood, and definitely to then attain a normal adult height. What is seen from all the long-term studies, it's not associated with any significant adverse effects or even in the long-term metabolic consequences. It is more effective if started in younger age who do not achieve catch-up growth because they can have more time to catch up. And majority of the children who are SG and treated with growth hormone, they do not have any change in their puberty. That means there is no change in the bone age or there is no change in the pubertal onset or progression, and it happens as normally as a AGA child. In India, also by Dr. Khadalkar, we do use growth hormone therapy, and this is the children who satisfy the height age Z-score who are below -2.5 or whose growth velocity is below the mean or their height SDS is below 1 standard deviation of the mid-parental height. The age of starting is 4 years, as it's approved by the European Society also, but if there are children who are continuously growing below their standard deviation and faltering, then the growth hormone can be started even between 2 to 4 years. Bone age cannot be a good parameter to predict adult height in this case, so that should not be used. We have enough studies to say that the standard deviation improves by plus 1.2 to plus 2 for doses which are much higher than that we use for growth hormone deficient children. We do use breaks in growth hormone deficient children, but in these children it's better to use a continuous therapy, because once they are off the therapy, the growth velocity goes down, and again you're wasting the same amount of time to take them back up and then to maintain that growth velocity. The second and the most important is the obesity and the metabolic syndrome, because these SGAs have low lean mass and increased central adiposity. So, and also because of that, the BMI may not play a very good role in identifying them. It is important to plot them on the growth chart and see if they are changing the centile lines very frequently, which is called a rapid catch-up or rapid weight gain. And these metabolic risk factors can track from childhood to adulthood. So it is important that even though these children are small, caloric dense feeding should be avoided, and it should be a low fat balanced diet always. Young adults who are born SGA have a higher incidence of metabolic factors, almost 2.3% as compared to those born AGA. So we know IDF has provided the definition for metabolic syndrome. All of us are aware about this, where we don't take the body mass index, but we take the waist circumference. And it is identified based on 2 out of these 4 characteristics, which is triglycerides, HDL, blood pressure, and the glucose. So what are the modifications to this? This is a very well-known table. So one is, how do we identify the waist circumference? What the IDF says is more than 90th centile, but from Dr. Khadalkar's papers, we know that if we wait till 90th, then we've already seen metabolic syndrome in these children. So 70th centile should be used as a cutoff, and this is how we measure the waist circumference. It's a midpoint between the lowest rib and the iliac crest, and it's not around the umbilicus. And hip circumference is the largest diameter around the hip. Okay, this is the 70th centile for boys and girls, and these are the numbers. So you should identify these waist circumference, which would be a high risk for metabolic syndrome. Besides the waist circumference, we have waist to hip ratio and waist to height ratio. So for the blood pressure, we know that American Academy of Pediatrics have updated the definitions, and that's what we should be using and not what the IDF has given. Secondly, Indian Academy of Pediatrics has revised the diagnosis for diabetes mellitus. It should not just be the fasting blood sugar. There are more parameters added to triglycerides, and another additional will be the non-alcoholic fatty liver disease, which is identified by ultrasound and SGPT. So the main management would be prevention, prevention, and prevention. And the main cure or main treatment would be lifestyle intervention. Obviously treating the associated comorbidities. Do we have any drug for obesity or weight lowering? We do have those drugs, but we don't have enough data. We do have Orlistat, we do have liraglutide, but also Orlistat is used after 10 years of age and liraglutide in adolescent, late adolescent. So no, we don't have any treatment for obesity. For morbid obesity, it is bariatric surgery, but we also know that we don't have enough data, and bariatric surgery includes a lot of lifestyle intervention just besides the diet and the physical activity even thereafter. Third, going to puberty and adrenarche. Most children do have normal pubertal timing. Pubertal growth may be decreased, and this is because in girls the menarche can happen 5 to 10 months earlier. Usually the interval between thelarche and menarche is 1.5 to 3 years. This interval can be shortened so that they probably don't get enough peak height velocity duration. There is a rapid progression to the puberty, and hence they lose the adult height. The ones who gain weight rapidly are more likely to have adrenarche. Adrenarche is also a risk factor for early onset puberty, menarche, and polycystic ovarian syndrome in girls. So it is very important to avoid the child to go through all this sequence. Again, bone age will not be an indicator for pubertal timing or adult height gain in SGA child. Management. So it is important to know at what age the child is going into puberty. Early, everyone knows that precocious puberty, it's GnRH analog. But if the child is going into puberty at appropriate time, but at a height which is less than at least 130, the international guidelines say 140, but if it is less than 130 centimeter, they may warrant both growth hormone and GnRH analogs. Thyroid, usually no major alteration, but we should not forget that newborn screening for congenital hypothyroidism should still continue in every child who's born in all over the world. And we do have the guidelines provided by the Indian Society of Pediatric and Adolescent Endocrinology in 2018, where TSH, either on day 3, cord blood or day 3 or day 5, more than 20 is recalled, and any TSH which is more than 80, this is for term. So any TSH which is more than 80 or a TSH which is more than 20 in first 2 weeks of life will warrant treatment. Whereas coming to these preterm babies, there should be a routine screening at 48 to 72 hours, sick neonates at 7 days, and all preterm should have a repeat test done after 2 weeks of their birth. Okay. For the other endocrine consequences, not much to do with the HPA axis. Ovarian function, yes, adrenarche, obesity, hyperinsulinism can cause polycystic ovarian syndrome and reduced ovulation rates maybe in adulthood. Bone metabolism, we do know that SGA is associated with reduced bone mineral content and bone mineral density, but this is reduced once the height is adjusted, and low birth weight is not a significant predictor for fractures in adults, so we should not be just ordering DEXA for them. They should be given the same supplementation as we give it for term AGA or preterm AGA. What happens in adulthood? So women and possibly men who are themselves SGA are reported to have increased risk of having SGA infant. Women who were born SGA could have PIH and gestational diabetes. Though this is not enough to tell us that we need to have a regular surveillance for every adult born SGA. Screening procedures for cardiovascular risk factors, cancer and osteoporosis is the same as for the adult, for the general practice. Yet, we do need a long-term surveillance data for adults who have been treated with GH. Okay, so then just give me a few minutes because I was going on that. Okay, so just coming quickly to the case scenarios because now they've told me that I have less time than what is projected over here. So this is a 14-year-old boy who had come because the parents were told that the child will catch up growth once the child goes into adolescent, and they found him to be short. So looking at this parameters, the child is within the MPH range, if you can see here, but he has already developed a testicular volume of 25 ml and there is a facial hair and voice change. That means he's almost completing his peak height velocity. And if you look at his born age, it was 16 years. So yes, this was too late to refer a child, and obviously the myth that the child will grow later should not be followed. So even though we followed this child, he just stopped growing after 6 months of age, and he actually landed up to be a short adult. So, but there was a rising BMI, so obviously there should be counseling regarding the lifestyle intervention. At the same time, the brother also tagged along with him. He was full term 2 kilos, and this is what we found him on the growth chart. Since he was growing below the 2.79 standard deviation, we did offer him the evaluation and treatment which the family could go ahead, and hence we did start with growth hormone. And if you can see, there is a change in ST of almost +1 by starting the growth hormone therapy, and almost after 3 years of use of growth hormone therapy, there is not much change in the body mass index, there is not much change in the bone age, and the pubertal timing probably will remain the same because the child has still not gone into early puberty. So this is a typical child of SGA who's failed to catch up. As you see on this growth charts, that the child had come at 3 years and has the height below 2.5 standard deviation. So definitely needs referral and SOS, the growth hormone therapy. Okay. This is the case where the 9-year girl presented with menarche, though the parents had noticed pubic hair at 7 years, but due to the pandemic, there was a usual scenario right now, they were lost to follow-up, and there was an excessive weight gain in last 2 years. So what you can see here is that the child did have some pubertal peak height velocity, but if you look at the bone age, it is 11 years, almost 2 years more than what the child is having right now. And if you look at the weight and the BMI, the child is definitely obese. So besides being SGA, obesity also kind of triggered early puberty in this child. So what would be important? Yes, this child will require GnRH therapy, but if you can see, the height is 130 centimeter and we still have time for the fusion of bone age. We could still offer growth hormone therapy as well. On examination, this child had acanthosis nigricans, so definitely will require a worker for the metabolic syndrome. The last case over here, this is a child who's regularly being followed, and if you see, there is a rapid catch-up of weight. If you can see this is called rapid catch-up of weight which has happened, and this child's weight for height was crossing even the +3 standard deviation for obesity. So definitely this child would require thorough counseling and surveillance to prevent any premature adrenarche, pubarche, and ultimately landing up in a short adult. So to summarize, it is important to identify the SG infants. Regular monitoring should happen every 3 monthly in the first 3 years and 6 monthly thereafter. We should look for catch-up growth and catch-down growth in these children based on the growth chart plotting. So anyone who has a rapid catch-up growth, they should be evaluated and they should be under close surveillance for any adrenarche, pubarche, early puberty, and obesity-related metabolic complications. Children who do not catch up, there should be a referral to an endocrinologist between 2 to 3 years, and ruling out if there are any other factors, this child would warrant a growth hormone therapy. The child, if they had a good catch-up growth and it was not rapid or it was not lacking, then they should have an pubertal assessment starting from 6 years, as IAP has also recommended, to avoid any early onset of puberty and rapid progression. Thank you.
Thank you, madam, for a very detailed presentation. I think the take-home message is very clear. First of all, management of an SGA does not end in the infantile period, whether it should be instead taken as a beginning for some children. And the second point is growth charts. It is an indispensable tool for every pediatrician, so urge to everybody to maintain good meticulous growth charts here.
Thank you, Dr. Ruchi Parekh, for that excellent deliberation on a very important and clinically relevant topic for us, general pediatricians. With that, we end our third session, and I would like to request Dr. Alok Sardesai to kindly felicitate Dr. Ruchi Parekh, our guest speaker today. Dr. Alok Sardesai, pediatric and adolescent endocrinologist in Thane and in Mumbai. Thank you, Dr. Alok Sardesai, and thank you, Dr. Mahendra Kelkar.